answer will be provided at the end of the meeting under item 10.2. And we have several members of the public signed up to attend, as well as the standing invitation to our mirror board. May I start, please, with declarations of conflicts of interest, either new or relevant to today's meeting? Looking around the screen and I can't see any, thank you. And then the draft minutes of our joint meeting in public on the 13th of January 2026. Any comments or amendments? May I take that as an accurate record? Thank you. And anything that we would like to raise that's not already covered in the agenda for today? Thank you. So before I hand over to our CEO, Nick Broughton, I'm going to say a few really fulsome thank yous to the people on this call. We have come together as the joint committee from the separate committees of Bob and Frimley, the separate boards. And I want to say thank you to all members of the committee and to all members of those boards, some of whom will be leaving us as we move into the Thames Valley. The guidance, leadership and commitment that everybody has shown has been extraordinary. And I think Nick and I would be very, very fulsome in our thanks to all of you. And I know many people on this call would also like to contribute and to note their time as well. So without more, I'm going to hand over to Nick. Thank you, Nick.
Thanks, Priya. And I'm Nick Broughton, Chief Executive of both the Bob and Frimley ICBs, and I can only echo what Priya's just said and extend my thanks to all our board colleagues for the support and guidance they provided, particularly since April last year. Priya, I will take the report in the pack as read. Just a couple of things to flag. Firstly, from a personal perspective, you'll see that I began my secondment to NHS England and the Department of Health as a National Priority Programme Director for Mental Health, Learning Disabilities and Neurodevelopmental Conditions earlier this month. Clearly, that's something that we need to include in the declarations of interest for board members. A couple of significant appointments in recent times in our system. That just want to flag that James Blythe has been appointed to the role of Chief Executive of the Royal Berkshire NHS Foundation Trust and will succeed Steve McManus in May. And more recently, Raghuv Bassam was appointed to the role of Chief Executive for Buckinghamshire Healthcare NHS Trust. Raghuv has been the Trust's interim Chief Executive since October. Really pleased with both those appointments and very much looking forward to working with both James and Raghuv during the months and indeed years ahead. We'll touch on this later in today's agenda, but we are in the midst of a fairly significant period of organisational change with the transition to Thames Valley ICB. And I am, and we are as an executive team, very aware that this is impacting on individual colleagues across both organisations in a very significant way, not least on those who will be leaving the organisations through voluntary redundancy. And our thoughts are with those colleagues, not least because we're very aware it's been a very difficult decision for many to decide whether they wanted to leave the ICB or not. And I'd like to just put on record my thanks to them for all they've done to support the ICB and indeed the wider health and care system during the course of their tenure with us. Finally, in terms of our relationship with the region, we had our third quarter assurance meeting with the South East regional team on the 25th of February. We are awaiting formal written feedback following that meeting. The verbal feedback was largely positive regarding the progress that's been made by both ICBs, but also in relation to creating the new Thames Valley ICB. And I think it does reflect that we are in a rather different place now than we were 12 months ago. So that bodes well for the future. Priya, that's it from me. I'm conscious the report includes sections from a number of executive colleagues who I'm sure will also be happy to take questions from the wider board.
Thank you very much, Nick. Do I have any immediate comments and questions? If not, we will start our deliveries of 25-26 priorities. Come in, Ilona.
Yeah, sorry, it's just a tiny point. Nick, I know the kind of internal communications about your secondment into the national mental health role stressed this point, and I wondered, just because this is a public meeting with a public record, A, congratulations on that appointment, but B, perhaps you could just clarify that it sits alongside your ICB role.
Yes, indeed.
In case there are any alarm bells ringing.
Ilona, thank you very much for that. Sorry if I wasn't clear. Yes, it is a part-time secondment. I'll be working with NHS England and the Department of Health for half the working week. We're working through what that arrangement actually looks like, but in effect, I will be in London on Tuesdays and Thursdays. But there's clearly quite an overlap between my ICB role and the national role, which I think will be helpful for us. The other thing to say, as you'll be aware, we have a very strong and capable executive team who are supporting me in relation to this. So I'm confident that we can mitigate any risks associated with the secondment arrangement. But thank you for flagging.
Thank you very much. Thank you, Ilona. Let's move then to delivery of the 25-26 priorities. I'm going to start with Ollie and Matthew. Thank you.
Thanks, Priya. So it's Ollie White standing in for Rich Chapman. So just a quick update on the financial position. So we're working through the 25-26 position for the 2 ICBs, and we continue to operate a collective system control total in both of those respective systems, where we're focused on delivery of the overall position between ourselves and providers. At month 10, and details that you've got presented to you, we continue to mitigate some of the in-year risks that have been emerging around kind of ADHD, right to choose, and section 117. Those are being managed with some underspends across CHC and other areas, and some kind of non-recurrent one-off actions that we've been taking. We're on plan at month 10, slightly better than plan, and then at the moment we continue to hold our forecast to plan, and we anticipate being able to deliver this year's financial position. I think that's all I was going to share in terms of the finances. The position's looking good. The team working really hard to make sure we close out any residual risks for the financial year. Happy to take any questions.
Thank you very much. Did you want to come in,
yeah.
Matthew? Thank you.
Yeah, thanks, Priya. Sorry, apologies. Matthew Tate, Executive Director for Delivery. Just to give a few highlights, really, and update the board and the public forum in terms of performance, noting the, as always, the delay in data around the ability to publish performance information. So just pick up a couple of key highlights. On urgent emergency care, we progressed towards delivering the target of 78%. There is a national focus and support programme around delivering that percentage by the end of the year, and also during the month of March. And I'm pleased to say that overall as a system, so far in March, we're achieving that, and that does demonstrate a continuation of the improvement throughout the year. So as an example, Oxford University Hospitals have delivered over 81.5% so far during the month of March. So some really strong performance in UEC, which I think reflects on the transformation and work that's happened across the system, and also the support of primary care community providers and local authorities in supporting that flow across the system. On elective, the national focus, as I've highlighted previous board reports, is the focus on the RTT percentage as we head towards the end of the year, and also the overall waiting lists and long waits as well. The system has invested an additional £5 million of funding provided nationally to try and secure improvement by the end of this year. And for example, all our trusts have agreed stretch targets during that period to try and improve the position. So for example, RBH have agreed a stretch target of 83% for RTT. So broadly, I think our trust will get close to those targets. I think we do need to recognise that there is a pressure in balancing the delivery of the percentage on treatment times within 18 weeks with the overall wait lists and the long waiters. And so we may see some trusts not able to deliver all three of those towards the end of March. But if you looked at a linear line across the year, what you will continue to see is an improvement in performance throughout the year, and I think a drive towards the end of the year to get those numbers down and to put the trusts in the system in a strong position as we go into the new financial year. In terms of the cancer area, that remains one of our most challenging areas, and I've said to the board before, particularly around 62-day performance. And whilst we again have seen a genuine increase in performance throughout the year, we have seen some challenges, particularly for Oxford in the early part of this quarter. But again, we have put additional investment in that last quarter to try and drive that down, and are confident we will see some improvement as we head towards the end of March. That's just a few headlines, Chair, to bring out in terms of performance, and as always, happy to take any questions.
Thank you very much, Matthew. I'm going to invite our Chief Nursing Officer, Sarah Bellas, and our Chief People Officer, Sandra Grant, to come in with their reports, and then we'll have questions and comments in the round. Thank you.
Thank you, Priya. I'm assuming I'm going first, as you mentioned me first. So I just wanted to just share a few highlights from the report without going through it all, because I'm sure you've seen it all. In the beginning, you've got a summary of the complaints, and the themes around the complaints remain the similar themes that we've highlighted in the past. Never events, you know, we've had a bit of a focus on never events. Unfortunately, there have been 2 further never events at the Royal Berks, one of which occurred there, and one was found there from a foreign procedure. Then in terms of provider concerns that we shared at the previous board around the wheelchair services in Berkshire West and the work that we are doing in that area. We're continuing to work with the local authority to identify and quantify the problem. We have invested some additional money to support with the waiting list, and we are working through all individual cases that are reducing on a daily basis. We also are having a bit of a focus, as you are aware, on the EMID patient transport. This was a service that transferred last April from SCAS, and it's the non-urgent stuff, and we're working with the company to address that. We continue to have a significant pressure on mental health beds across the system, both in the Frimley side and the Bob side. I think the other 2 areas I wanted to flag was we're starting to get some traction on the leader programme now in the Bob side, which had been paused from January till December, and we have got reviewers looking at cases. So that should start to improve as we move forward, and we've got a plan of improvement for that. Thanks, Priya.
Thank you. And Sandra?
Thank you. With regard to the whole of the South East, there is a 2.2% over plan for workforce plan delivery so far at month 10. Bob is actually the only system that is delivering under plan, and I think that some of that clearly correlates to the financial position that we're in, as most of the costs that we have are relating to workforce. Frimley is over plan by 3.3%, and we've done a bit more exploration about where that is. They are under with regard to agency costs, which is always very positive, and over with regard to bank. So we've done, as I say, some more inquiries around that. Some of it is about how they've calculated things like Mars impact and under calculating the impact of winter pressures. So we are doing a process with the regional team around how do we improve workforce planning overall. Traditionally, what tends to happen in organisations go off plan from month 3 onwards. So that's our real focus there about what's the learning from that and how do we plan better in this space. Nationally, they are concerned around where we are expecting to make savings. There's not an awful lot of signs of big transformation taking place. It's predominantly in things like absence reduction, temporary staffing reduction, and infrastructure role support. So really understanding that, I think, is important as we move forward. With regard to the ICB itself, the workforce team have been really focused on how do we make sure we are safely moving out of 2 organisations and into one, to make sure payroll will be sound and staff records, etc., as well as all of the transformation work that we are doing around staff transferring in and out of the ICB, MAR schemes, voluntary redundancy schemes, and everything else about the whole organisational design that I know we will come into in the transition report later. So that's all I was going to say. Thank you.
Thank you very much. I have a number of hands up now. Thank you. Tim, I think your hand was up first and then went down again. So let's start with you, then Grania, Nick, Sajad, Sim and George. Thank you.
Thanks, Priya. Some confusion. I put my hand up and then it didn't flag on my screen that it had gone up, so apologies for the confusion. It was just a quick question for Sarah, as we're obviously in the public board. I just want to clarify the point around the 2 Never events. I saw that the one had occurred in Turkey and then the other one was an eye-related issue. How and when will we get an update as to the, it says investigations ongoing, just how can we reassure people and how will we be recording back what the learnings are from particularly the ocular event?
Better take myself off mute. So yes, we will get the update on that, and we've got a focused piece of work on Never events, and we've been bringing back the Never event work on a regular basis. So we will be sharing not only within the Royal Berks but across the whole of Thames Valley as we move forward.
And how would the public get to hear that? So is there
we'll continue to bring it in the into the public board, the learning and things that we've been doing.
Thanks, Sarah.
Thank you. Grania?
Yeah, thank you. And Sarah, just thank you so much for the update on the AGM wheelchair service. So really helpful, mindful that you've updated us previously on that. And really positive to see the additional investment that the ICB are making to reduce the waiting times. So again, thank you for that. Your focus on ensuring that children and adults are safe, again, to be commended. A little bit more on that one though. So there's quite a lot of people who are still waiting. I know that you've looked at a priority matrix of some sort in order to ensure that we're looking at the individuals who need the support first. How long do you expect it to be before we've worked through those the waiting lists and the people we're able to understand the impact of the delay in the service provision on those individuals? So I suppose, so 2 questions, sorry, I'm not being entirely clear. So the length of time to get rid of the waiting list, to reduce the waiting list, and then how we're going to understand, I suppose, what a reasonable waiting time is for people. And it might already be built into your contract moving forward. So it's waiting well, isn't it? And ensuring the impact of the wait is minimal on the individuals moving forward.
Actually, that's a really great question, and that's one of the things that I've been trying to highlight to people, that actually there's a national framework for wheelchairs and waiting lists and things. So I think our ambition would be to get to being compliant with the national framework and service specification for wheelchairs as soon as possible. We're working with the company to understand what that looks like. At the moment, we're prioritising in terms of harm and potential harm, but then we'll move into that framework. And Matthew might have more detail, and he's put his hand up, so it might be helpful if Matthew comes in at that point.
Yeah, just to I think that's a really good summary, Sarah. I mean, just in terms of the waiting list ambition, we've invested £500,000. That is with the ambition of getting back to compliance with the national 18-week target within 12 months. So that's the target for that investment, Grania, to get back to the national 18-week target within 12 months.
Thank you.
My ambition would be we would have a trajectory that we would be monitoring and that we could bring it through here for transparency.
Thank you. Come in, Nick.
Yes, Sarah, sorry to bombard you with another question, perhaps a point of clarification, but in relation to the Never event concerning the vaginal swab following surgery in Turkey, is that included under the Thames Valley Never event list, as it were, or do we log it somewhere else, conscious it happened in a service outside those we commission?
It does contribute to ours, but I think it's better that, you know, we had a conversation with the trust. I think it's better that things are reported and that we find ways to learn from it and share that than not. But I think we will continue to remind people that it occurred in another country and it wasn't attributed to the Royal Berks or to the system.
And is there a system in place whereby this can be flagged nationally in case there is a provider in Turkey where there are recurring problems?
Yeah, so Never events are one of the ones that continually get reported. So that goes straight up to the national system through the reporting system. So they will be able to theme it. We've also will be flagging it through our escalations to region.
Right. Thank you very much. Thank you.
Thank you, Nick. I think that's such an important point because, of course, the whole point of Never event reporting is to be able to put systems and processes in place to prevent them happening. And if the reporting cannot possibly result in that because the event did not happen within the systems that we have control over, then we need to find a way to ensure that that is fed through. So thank you, Sarah. Sajad.
Yeah, just a question for either Sarah or Matthew. We had the recent bone cement supply chain problem. That followed on from equipment failures earlier in the year with NRS, I think it was. Are we seeing significant impact as a result of these supply chain shortages, both in terms of waiting list and electives as well as emergency?
Do you want to come in, Matthew? Because I think there's two parts to this. Do you want to?
I think you're right that they're very different. They're very different issues, but I think they're fair points. So on the bone cement, the impact was limited. So that was established as a national incident response, but there were some cancellations, but they were minimal actually in terms of we identified an alternative supplier quite quickly. So that had a minimal impact. The equipment impact, I think we kept an eye on that throughout the course of that transition, and again that has some impact in terms of discharge. But again, I think credit to our partners actually, and including local authorities, in finding innovative ways to minimise that impact. And we haven't got a way, I don't think, of capturing the totality of that impact in a systematic way. But we were working very close with partners at the time to identify it. But I think in terms of context, obviously there is a difference, I think, between services we commission directly and supplier risk and failure, and those that are broader parts of supply chains. So I know that we've discussed an executive with Sam and others about how we make sure we've got a good line of sight on any risk in terms of supplier failure moving forward.
And I think in terms of supplies, so two things. One, in terms of NRS, we have been able to monitor to some extent the harm and the challenge with it through DATEX reporting and safeguarding referrals as a result. So I think it's not. I think Matthew's right. We haven't been able to do the totality, but we do keep an eye on it, and there are still some delays that are associated with that transfer, and we're aware of them and working on those and using that information. In terms of supply fails, it's not an uncommon thing to find that something or some medication becomes very short and scarce, and there's a national reporting system to do that, and work happens very quickly to try and source something alternative or do an alternative thing to try and minimize the impact on patients. There is a national route for that we are quite well practiced in working through.
Thank you, Sarah and Matthew. Distinguishing the sort of resilience of the organisation as opposed to the resilience of the supply of a product is a good distinguishing to make for us, and we'll have different approaches to the two. Thank you. Sim?
Thank you, Sarah and Matthew. Could you talk to us a little bit more about the pressure on the mental health beds? I know this is something that we know we have a problem, and I know that it's not in our direct control. But Sarah, can we assure the public that we're thinking perhaps of different mitigations for this, or different ways of thinking about how we might solve this? For example, working more closely with the VCSE. Is there a way of being able to look at this differently as we move forward, to help release some of that pressure?
I'm not sure that the VCSE is probably a place where we would be looking to get support in this area, but thank you so much for the question, because one of the things that I always worry about is that we don't have enough attention on the mental health beds and the delays as we do on corridor care and other things. And from a mental health perspective, this lack of beds is as serious as corridor care or delays to admissions, etc. So really appreciative that you've asked that question. In terms of what the problem is, obviously the problem is beds. It's about discharging people from the acute bed so that we can move new people into them. So it's a flow problem like the acute, and it is just about trying to do that and making sure that we do that in partnership. So I think it's highlighting it on the agenda as we're doing. It's about working together effectively as a system to maintain the flow through them and have as much attention to it as we do to the acute pressures. I can see that Matthew wants to come in, and Nick probably is national mental health role.
Yeah, and I dare to hesitate to say anything before Nick in his new national role. But I think just to reassure you, Sim, there is ongoing work taking place. So there's ongoing work around sort of capacity and demand modelling around the bed stock. As Sarah says, there's ongoing work to look at flow, best practice of flow. There is a national expectation that we reduce out of area placements to as low as possible. And also this is a key work stream for the mental health provider collaborative as well, in terms of managing that bed stock. So lots of work going on across our system to try and address the challenges. And broadly, I think we are in a much stronger position than some of our neighbouring ICBs, who I think are really struggling in terms of mental health bed stock, and Nick may refer to that in terms of the national position. Our trusts do extremely well in terms of benchmarks on this.
Yeah, that's exactly right. We have a relatively low bed base, so the number of beds per 10,000 population is lower in our patch than most other parts of the country. What we've seen nationally is a significant increase in average length of stay, on average by about 10 days over the last decade, which is quite remarkable, really. But we do have an issue with delayed transfers of care, or patients no longer satisfying the criteria to reside in hospital. Probably 10% of patients at any one time, or service users at any one time, do not need to be in a mental health bed. There are issues in relation, I think, to how services are configured internally in relation to that. But there's also an issue in relation to the interface with local authority colleagues, and a lack of supported accommodation for individuals with particularly complex needs. So, as is always the case, Sim, it's multifactorial, but we do perform pretty well compared to most other systems, and we're lucky to have two strong community and mental health trusts in the Thames Valley system.
Thank you both. And George?
It might be something more to take offline, but just to flag, obviously, on the cancer targets, it looks like there's a real consistency in gynae, lung and upper GI as the challenging areas across, I'll be frank, all four trusts, although Frimley's performance is significantly above the others. I just wonder, A, where we benchmark in those areas nationally, is that a Thames Valley issue, or is it just a national issue? And B, whether you kind of know where the root cause is it diagnostic capabilities, workforce? because it feels like if it's consistent, we can try and find a single solution across the system.
It is broadly consistent, George, in terms of some of those pressure areas across the trusts. I'm not so cited nationally, but I suspect they will be a national challenge as well. The underlying cause, as always going to say, are multifactorial. Some of them relate to workforce shortages. Some of the challenges around Oxfordshire are about capacity and relate to theatre capacity, and hopefully will get resolved once they've got their new surgical elective centre. But some of the challenges we do have, so for example, some of the ranking on lung, for example, I know that Oxford is struggling there, so that's presently in the bottom 10% of the national standard across, and that's across all 124 trusts. So we do struggle, but it's a bit of a mixed picture. I'm happy to share a bit more detail offline if helpful.
Thank you very much, Matthew. Thank you. I can see no more hands. I'm going to move us then to the next part of our agenda, which is the transition element. So the Transition Programme Director's Report, and we have Caroline Corrigan, our Chief Transition Officer. Thank you, Caroline.
Many thanks, Priya. I'll take it that the report itself is read, and just want to highlight a few areas. I suppose the first thing to start in terms of context is we're 15 working days from the formal disestablishment of the two organisations, Frimley and Bob ICB, and our cluster arrangement, and go live with Thames Valley ICB on the 1st of April. So at 15 working days out, the top line for this joint committee, the two boards of the current ICBs, is we're on track to dissolve the two organisations and set up our new organisation. That our rather complicated picture of partnership working, particularly with partner ICBs and particularly to the south as the Frimley boundaries are changed, is a very live piece of work to enable the legal transfer and schedules associated with that to move contracts, people, assets and liabilities to Hampshire Isle of Wight ICB and to the new Surrey Sussex ICB. All of that is on track. There's a national deadline for that. We're one of a very few number of ICBs doing that by April 26, but we're on track with that delivery of those financial and legal frameworks to enable the transfer to partner ICBs. The other areas highlighted within the transition report hopefully give you a flavour for, whilst it's closed down, as it were, of two organisations and set up of the new organisation, it all just doesn't cut over on April 1st. So our work in the formal subcommittee of the Transition Programme Board continues in April as we assure through that structure that all activities are and their risks are mitigated. So the other area that is of significant priority focus at the moment is the national changes to the commissioning support units, the CSUs, and mitigating the risks around the close down of that organisation, the transferring in of staff from the CSU to the Thames Valley ICB, such that those services continue where we need them to continue, and the safe close down of CSU services during this coming calendar year. So our operating model as Thames Valley ICB still has reliance on the CSU for some services, and we're working actively nationally, regionally and locally on that close down programme and assuring that activities can continue. So that's the Southern Transfers and CSU in particular, against a backdrop of the 15 working days until the go live of Thames Valley ICB. In that context, we have our chair confirmed, Priya, the day one activities to appoint our chief executive, Nick, and the rest of the board arrangements are on track. And we have launched consultation, as Sandra referenced earlier, with the staff of the current 2 ICBs around the jobs that will make up the new Thames Valley ICB. That consultation process launched in February. We are active in many briefing sessions for staff to both balance a sense of excitement, hope, and understanding the difference of what this new ICB will be doing, and safely holding our people, given the fact that there will be redundancies expected as a result of the nationally determined reduction in our operating and running costs. Last word would be our thanks to colleagues across the Thames Valley footprint, but particularly FHFT colleagues, as both the board of FHFT and the joint committee are exploring in more detail now how we would transfer some of the ICB functions to our system partner and enable the safe continuation of services such as CHCC, AACCC, and also Meds Ops, and progressing that work at pace and very diligently to ensure safe transfer and continuation of services for the communities we serve on the Thames Valley footprint. Happy to take any questions, Priya. Hopefully that edited highlights of the transition programme report.
Thank you very much, Caroline. And I think everybody would echo very significant thanks to all of those who have been involved in doing this so well. It's a major piece of work. It's a major programme of work, and it has been done incredibly carefully and thoroughly. Thanks particularly to Sim and to Ilona, as well as the joint chairs of the Transition Programme Board. That has been an enormous amount of attention paid, and to all those that have been part of that. Let's move then to Sim and then Paul, please.
Priya, thank you. You said it for me. I just didn't want the occasion to pass. I think Caroline's very her description and her narrative belies the fact that a huge amount of work has taken place behind the scenes, and we've made it sound almost seamless. And I just want everyone to understand, colleagues, the public alike, that this has been extremely difficult, but the team somehow have been able to deliver this in a way that has really held the risk. We've identified, we've mitigated, and the other really important thing, as Caroline mentioned, we've been able to hold our people who are going through such a tricky time. And I think this has been done compassionately and with equity and fairness, and a constant review of how others feel under circumstances. So I just wanted to make sure, for the record, that was really clear. And therefore, on behalf of Ilona and I, as joint chairs of that transition committee, really to thank Caroline, Sandra and her whole team for getting us to this position. It can't be understated, and it's very important to constantly remind ourselves that this is a huge piece of work. Thank you.
So well said, Sim. Thank you very much. Paul.
Similar point, really, Priya, and so thank you, Tim, as well. So I suppose from my standpoint as the chair of the Remuneration Committee, and then doing that jointly with Sim, which has been a pleasure, I just want to recognise the kind of attention that has really been paid to thinking about two or three things, really. I mean, I think, first of all, really thinking about supporting staff through a significant period of transition and transformation. Secondly, particularly from a Frimley point of view, the attention that's been given to the southern transfers, as they've become known, for those parts of Frimley ICB which are moving to other other ICBs, which makes, as it has created, is a really important part of this process. And then thirdly, just really thinking about sustaining kind of continuity and commitment, not just of service, but also of a lot of the work that the people teams have been doing to lead and support staff to be the best staff they can be in these kinds of environments, and I have been incredibly impressed. So I hope, alongside quite a lot of other things that have happened over the last couple of years, that we will find some time once, maybe possibly after the beginning of April, to do two things. One is to really kind of think about what we've collectively learnt from this process. None of us can discount the possibility of other changes going on in a system in the future years, and I think it would be really good for us to make sure we capture some of that learning. And having started in the Frimley ICB about 3 years ago, many people will recall those first early months of that when there was a lot of transition going on as well. So I think it'd be really helpful to make sure we take some time to capture the learning and listen to people's experiences of that as well. And then the sort of second part, which is kind of connected to that, is a piece about how do we, given the environment that we're in the public context, so how do we then start, and Nina will come on to this in a moment, how we then start talking about that transition for staff, for volunteers who deserve mentions in this space, and of course for the wider public. And I know we'll come on to that in the next item, but just a huge thanks to colleagues for the work that has been done and for the very high degrees of professionalism, sometimes in the context of things coming down from different places that make this journey harder. Thank you.
Priya, are you happy? I'm just going to yeah. Oh, you're on mute, Priya. Sorry, I was just going to thank Paul. Yes, absolutely. Sim, Alona, myself, with Alison have been talking about, right, how do we capture the lessons learned, and maybe not creating a massive report, but actually how do you do that dynamically, such that those lessons learned can be codified and help us lean into the future, that have a feeling there'll be more change ahead. So how do we reflect on the change, the processes, yes, the tasks, but actually the culture underpinning that and the ways of working to help us both lean into the future and embrace, no doubt, more change ahead. But thank you, Paul, for that.
Thank you very much. And to reflect also the significant work that has been undertaken in relation to what we've termed those southern transfers, as people have said, and really the leadership Lance McCarthy, Karen Edwards, Graham Wareham have shown in making sure that we do that well and understand how that is going to work well. So thank you all. I'm going to move us now then to the second part, which is the planning submission. And I'm handing over to Hannah Iqbal, our Chief Strategy and Commissioning Officer, and to Ollie White, our Director of System Financial Sustainability, who's here for our CFO, Rich Chapman. Thank you very much, both.
Thank you, Priya. So I'll kick off and then hand over to Ollie. So as Caroline said, in 15 working days, the new Thames Valley ICB will be established, and it will be established with the core purpose of improving population health, reducing inequalities, and ensuring consistent access to high quality services. And the way that the organisation will do that is by planning and resourcing the right services across our geography to meet our population's needs now and in the future. And we have considerable scale and resources to do that. So we have an ability to set the outcomes we want to see for the investment of £5.6 billion of healthcare budget, which is equivalent actually to the healthcare budget of Slovenia. So it's really important responsibility that we're moving into. And in line with the 10-year health plan, the NHS is moving away from annual planning towards a medium-term approach. And the 10-year plan says that that's to create headroom to fix the fundamental problems we face in parallel with improving care in the immediate term. And that's really the frame within which we've approached planning this year. So we were planning for the Thames Valley geography without really the organisation existing. So it's quite a challenging task. And what we've tried to do this year is balance the short and longer term horizons, both in our discussions in this forum and others, and also our engagement approach within the system. So the paper sets out the approach we've taken to the planning submission. We submitted a financially compliant plan that was compliant in terms of performance, noting inherent risks within that. And Ollie will probably want to expand on that in a moment in terms of how that's been taken forwards into the contracting round. And as the paper sets out, in addition to that, we launched the Thames Valley Innovation Fund. And the purpose of this has been to encourage an open conversation with our partners about the kind of model of care and services we need in the Thames Valley to better meet the needs of our population now and in the future. And we'd never done this before, so we were kind of learning as we go, but we were really struck by the wealth of interest and energy around this question of how we improve outcomes for our population and improve access to services. We had 192 expressions of interest, which the majority were partnership bids for different ways of doing things. And we've been working through with partners on this call and outside to prioritise them in terms of 5 priority programmes as set out in the paper. And over the coming weeks, we're holding workshops to further finesse these and agree the allocation of the remaining funding. It's important to note, though, that the remaining funding within the Innovation Fund is only 15 million. So what we really now need to do is start moving into thinking about that wider 5 billion and what we do with the resources we have on a greater scale as we become a strategic commissioner. So just finally to say thank you to the board, to our organisations and to our partners for engaging with us really productively in a challenging planning round. As Paul said, similar transition, we've learnt a lot and it's given us, I think, a good foundation for the work we now need to do as the Thames Valley ICB. Thank you. Ollie, do you want to build on what I've said?
Yes, thanks, Hannah. So yeah, just to provide that quick overview from a financial point of view, we have submitted a plan that's compliant. It sets out our intention to break even. We know there is significant risk within that. We have a challenging efficiency programme to ensure that we are driving the productivity improvements that are expected of the NHS each year. So as an ICB, we're looking at just around 4% efficiencies across our key areas of discretionary spend and the spend that we can manage. The other important factor is that we have alignment in terms of the contractual assumptions that we have with our key providers across the system, and that's really the focus that we're moving to now. There is still a significant gap between the assumptions that the providers have and we are holding, and the focus is now how do we start to close those gaps, provide clarity to the system of what people need to deliver, so that we can start the year with clear plans. I think that's another bit that is important to note as well. This is, I think, the first time in a number of years that we have a chance of having plans and contracts agreed at the beginning of the year rather than halfway through the year. And again, Hannah, back to the multi-year planning, that puts us in a much better position to make the changes that we know we need to deliver. So significant work still to work through over the next few weeks, and continue to work and engage with all the partners across the system.
Thank you both very much. Nick, can I bring you in?
Yeah, thanks, Priya. So I suppose I begin by just highlighting quite how much work has been undertaken to get us to this point, at the same time as the transition work that Caroline so succinctly summarised. You know, it's been quite remarkable on many levels that we've been able to progress medium-term planning far earlier than we've ever submitted a plan before, for a system that is yet to exist. and at the same time are now within touching distance of creating the new Thames Valley ICB. And on top of that, being able to deliver in relation to this year's plan. And as we touched on earlier, we're in a far stronger position, certainly in terms of financial performance and many aspects of operational performance than we were 12 months ago. So I'm very encouraged by that and very grateful to the leadership team for everything they've done to get us to this point. Planning has been, I think, a constructive and a far more collaborative exercise. I'm really pleased with the introduction of the Innovation Fund. I think it is an example of strategic commissioning in action, and it's great that this has elicited so much interest and enthusiasm from stakeholders across our entire system, particularly colleagues in the VCSE sector and also our local authority colleagues. Clearly it's something we've not done before, so there have been a few teething problems, and I think we'll learn a lot from this exercise, which will inform our approach moving forward. There are challenges, as Ollie has alluded to, which we are still working through as we head towards signing off contracts at the end of this month. We've got meetings scheduled, and we've been working very closely with colleagues from our provider organisations, and there's a CEO's meeting this afternoon, which Ollie and Hannah will be attending as we look to sort of finalise the detail. But a reasonably good position, more still to do, but I think this is a positive step forward in relation to the role of the ICB as we look to the future. But as always, some important lessons to be learned.
Thank you very much, Nick. Let me bring in Paul.
Thanks. Really good to hear the solid approach to thinking about the future and the planning. And clearly, there's going to be a lot to do as we get this new system up and running. I just want to make two very quick points. Firstly, is to really commend the Innovation Fund concept to everyone. I think it's a really imaginative way of starting to help all of us to think differently about how health care is delivered. And that's going to be really important going forward as we meet the challenges of a population which has significant health needs. And the Innovation Funds opens up the door to, obviously I have an interest as a chief executive of a large national charity, but to charities, local, but not just large ones, but small ones, local community charities, faith-based charities, organisations who can connect into particular communities in the area. And I think it's a really important way in for supporting and enabling a different approach to health, and particularly as we start to think about that shift from hospital to community, and also that shift into really thinking about prevention and helping and supporting people to really get the help they need from within their communities as well as from the NHS and its partners. And just on that note, I think just wanted to pick up, there's been a bit of a strand of a conversation earlier about sort of prioritisation for mental health, and I think it is really important that there is a real priority given to supporting the mental health of the community generally, and in particular young people's mental health in the next phase, not just because of the immediate needs that young people face, but also from the broader point of view of this is exactly the definition of early intervention, isn't it, for future healthcare. So pleased to see that being given some real focus going forward. Thanks very much, Priya.
Thank you very much, Paul. Come in, Ilona.
Thank you, and thanks, Hannah and Ollie, for the updates. And I was just reflecting on the amount of work that went into getting our plans to the position we've reached. And I know there's still further work to do, but actually I wanted to look even beyond signing off the plans and have just flag, I guess, that the importance as we move into next year as Thames Valley in thinking through what will the information flows be up to board to support assurance of how we're doing against our plan, and where are assumptions planning, proving to be correct versus where are our original planning assumptions proving to be less correct, and what are we, how are we adjusting our course as we go. But also thinking through, I mean, Hannah, you did a nice opening section there around what the ICB is for, and I think we have clarity around that, but what's changing is how we deliver against those strategic objectives. And I was just thinking again, how do the information flows support us to gain confidence that we are shifting in our approach and delivering in different ways to support things like the left shift, etc. So it's a comment really, just I think as we move into that next year, let's take a step back and think through how we support getting assurance that we're delivering in the ways we were expecting to or not, and also are we changing the way we operate as a system to support those more long-term strategic shifts. Thank you.
Thank you very much, Ilona. And I think that is a key consideration as we go forward. Not all constitutional targets will, of themselves, make us move to that shift. And so our own metrics around that and how we have those metrics that are across all system partners are going to be really important as we move to that, with constitutional standards sort of embedded in how we're reaching that. Thank you all. This next part of our agenda is for both the individual boards. Sorry, was that Tim? Come in, Tim.
Yeah, sorry, thanks, Priya. I just wanted to say a couple of things on the planning section. First and foremost, and others have already said it, great big thanks to Hannah, Rich, their teams, and all their teams across the partners, because it's a joint effort across many organisations and many people. And echo what Nick said, this is a different league in terms of where we are now compared to previous years, and I think we're probably also somewhat leading or in the leading group nationally in this. And I think the members of the public on the call should be reassured and proud of that the team here are really doing things differently and better than many, which is great. A big part of that is the database, the database element of this. So this isn't just about who shouts the loudest or who's got the ear of various influential people. A lot of this is driven by facts about the shape of our population, how it's changing, how it's going to evolve in time, and we're trying to match resources to that, which is, I think, what everyone would agree we should be doing. Echo what Paul said about Innovation Fund again for the public. This is really important stuff. It's small amounts of money relatively, but in absolute pound notes, it's still big money, and it's the first steps on a new way of working, which I think Ilona touched on as well. This is what I think most people in the country want: a left shift away from treating illness and trying to prevent it, and reduce inequalities, improve access, all the stuff that ICBs were set up to do in the first place. So I think it's really important, and it can often get lost in a very big agenda. But having said that, there's one slight fly in the ointment, which is just to point out that financially it's still very challenging. Ollie has pointed to the fact that we're putting forward a break-even plan, which is brilliant. But within that, there are lots of challenges. Lots of people need to be aware in the broader society that things are very difficult. We have perhaps got more money than ever before, but it's still, there's bigger demands than ever before, and it's very difficult. And in terms of meeting everybody's demands, that's going to be tough, and not everybody will necessarily get everything they want. And we have to manage people's expectation that while things hopefully will be better than ever before, they still won't be perfect. And we need that frankness and openness both within ourselves and with our partners, within the different trusts within this in the area, but also with the public. That we can't have everything. We can't have everything tomorrow, but we'll do the best we can to try and deliver that. And I think Hannah and the team have got a plan, a framework that we can do that within. Thanks, Priya.
Thank you very much, Tim. I think that's very helpful, and it does set the conversations absolutely as they need to be with all parts of society in our system. Thank you. I'm going to hand now to Safina Nadeem, our EDI lead, and Sandra Grant, our Chief People Officer, to take the public sector equality duty reports for both ICBs and then the gender pay gap reports for both ICBs before we then go to the Work Well programme. So thank you, Savina and Sandra.
Thanks, Priya. Can I propose we do the gender pay gap reports first and then the public sector equality duty, because we have got a presentation for that as well. So I'll
Perfect,
kind of
yes.
start with the Frimley. Thanks, Priya. The Frimley gender pay gap. So people will know organisations with more than 250 employees have to publish an annual gender pay gap report. It's a legal requirement, and that means looking at mean and median hourly rates, pay distribution across the 4 quartiles, and bonuses which don't really apply to the ICB. So this paper represents Frimley's gender pay report as of 31st of March 2025 and Bob's as of 31st March 2025. So in terms of Frimley, women make up around 72% of the workforce and 28% men, which is kind of aligns with national average around it with the NHS. We've got in Frimley a mean gender pay gap of 21.9, meaning that women's average hourly rate is 21.19% lower than men's. It's a small improvement since the last report, but not significant. And then the median pay gap is 26.2%. And what that indicates is that the midpoint women earn 26.2% less than men. So is it a slight increase? Again, about 1%, but not significant. Women make around 72%, but actually underrepresented in the higher paid banding and higher quartile, which is quartile 4, which that kind of drops down to 58%. And they are more representative in the lower banding, which is why we've got the gender pay gap. Looking at the trend since 2023, it's relatively stable. We've not had much kind of improvement. And when we talk about the kind of our ambitions going forward, I'll talk about what we want to do to help reduce that. We do have an action plan. I think going forward, we will look at a combined Bob and Frimley action plan for the gender pay gap. And like I said, I'll talk about that a little bit later. In terms of Bob, very similar. We've got 74.5% of our colleagues are women and 25.5% men. We find that in quartile 1, there's overrepresentation, so the lower banding have more women than the higher banding at quartile 1, which gives us the kind of gender pay gap we've seen. The mean average is 21.8%, 0.8%. It's a bit lower than Frimley, but still we mean that we have a median gender pay gap for Bob. The median is 11.15. It's a bit lower than the 2024 figures, but still we're still seeing that the pay gap there, and it's showing a steady drop over the last 3 years. That in 2025 for Bob, the hourly pay gap at median was 15% for women compared with men, and in the southeast, it's comparable with the southeast. Frimley is a bit of an outlier in the southeast, but with Bob, that's mainly comparable. And I think the main reason we're seeing the pay gaps in both organisations is that higher banding have more men and lower banding have more women, which is something that we're going to be addressing in the new action with the action plan. So looking at best practice, looking at flexible working, looking at doing a bit more deep dive around why we're seeing the gender pay gaps. We'll be developing an action plan for the Thames Valley going forward. So I'll pause there, Priya, or do you want me to go straight to the public sector equality report?
Let's do the public sector equality report, and then we can speak in totality. Thank you.
Thanks. So I think Kelly's got some slides. So what I thought we've sent the report to people, so people will know as part of our public sector equality duty, we do have to publicly address how we're looking at our inequalities. So how we're meeting our equality duty, public sector equality duty, also our specific duties around publicising how we our objectives, our EDI objectives, and also data about our communities and our workforce around protected characteristics. So this is our way of making sure we're addressing our duty under the Equality Act. So if you just do the next slide, really want to make this alive for people, so we can just pick out some of the things that we've been doing to help address inequalities. So some key highlights from Bob. Done a lot of work around the anti-racist work programme. So there's been lots of webinars, dialogues and discussions where we've completed work around anti-racism, and lots of teams are taking this work into their own teams and trying to address race and racism. Work on inclusive recruitment. Feedback from our staff networks is that there's lots of work that we need to do around recruiting inclusively, and that's really important now as we're going through our change program and transition program. So we're working with LinkedIn and we're working with external consultants to think about how can we start making our inclusive recruitment process more inclusive. Feedback from staff around reasonable adjustments not being delivered in a timely way. So Bob have published some guidance around that and really working with line managers to make sure that they understand reasonable adjustments and how to address them. Mentioned the gender pay gap. Bob also this year produced their ethnicity pay gap. Frimley hasn't done that, but going forward, we're going to be looking at an ethnicity pay gap as well as a disability pay gap as well. As part of the transition, Bob and Frimley have set up networks from the Staff Equality Network chairs to make sure we can use this network group to help us look at all the work that we're doing through an inclusion and fairness lens. And the equality impact assessments, we really strengthened that for quality and workforce through transition and through the restructure and consultation as well. Bob also been doing some work around cultural intelligence, and 121 staff has benefited from that across the system. And they're using that in different areas of work. And then the neurodiversity work that's been happening has been huge. And again, going to continue to do that across the New Thames Valley. And then other events that have been happening around Black History Month, disability and trans equality, really opening that across the region and the system to make sure all our staff are benefiting from that. Just the next slide, please, Kelly. Feel free for colleagues at Bob to come into this. This is around the engagement work that's happened in health and equality, and really linking to the work that kind of Hannah's just mentioned around the new operating model. I think continuing to work with our citizens, work with our communities, to make sure that we can use their knowledge and engagement to make sure that when we're delivering the new operating model that they're a part of that and they're engaged well. So these are some of the things that Bob have done in terms of reducing health inequalities. Puts lots of funding into prevention, locality-based schemes, wellness outreach programs. So lots of things around the grassroots-led projects as well in Oxfordshire with the plans there. So again, some of this is really key for when we take forward the new operating model in terms of working with our communities. In terms of Frimley, which is the next slide, just to highlight some of the key areas that we've done in Frimley for the last year. People would be aware of the Mirror Board programme. It was designed to kind of strengthen that leadership diversity across the system. It's been quite successful in doing that. We've come to the end of the first cohort, but we will be taking it into the new Thames Valley programme, and this has created development pathways for colleagues. There's people on the who've been part of the Mirror Board programme who have successfully had career progression. Lots of people have said that their confidence has improved. As part of a big part of the programme was a reciprocal mentoring, which had feedback from our board members around the benefits of that. Some of the key strategies that people have informed is the anti-racism strategy, looking at financial sustainability, and our core 20+5 return to reducing inequalities has been key as well. So overall, increased confidence and visibility and progression readiness. We did receive an award, which is the right picture there, from the EPANA, the Asian network, the national network, around best practice for equality, diversity, inclusion as well. So that's that there, and really keen for us to take this into the new Thames Valley organisation. Next slide, please, Sam. Bob have done a lot around anti-racism, and so has Frimley. So people will remembered we designed a anti-racism framework which is beyond boundaries, and that was very much a cross-sector alliance piece of work, and did lots of engagement with our partners, community, voluntary sector, local authorities to design this. And it's a maturity model where organisations can take the framework and use it internally with their own organisations, which is something that the system requested. So we've really designed that in a co-created way. And some organisations, I think Frimley Health and some smaller organisations are using this at the moment. Berkshire Health shared their learning from their Unity Against Racism programme, so building transparency and trust, but also we use that as best practice to develop our own framework as well. And we're really keen that anti-racism is owned across the system, so it's not just about individuals, but we look at a system approach to help address racism. And then again, we're doing some engagement around how do we use this framework to use in the new Thames Valley ICB. We've had a few organisations already contact us to say really keen to have this alliance across Thames Valley and to use this framework to help address the race inequalities that we are seeing. Please, the other bit we wanted to highlight was our annual EDI conference. So we've been having a conference every year for the last 4 years. This year we delivered it in partnership with Frimley Health Foundation Trust across the ICS. Really good attendance, really good engagement, some really diverse speakers. You can see some of the workshops that we delivered there. Really strong engagement from our partners. So it was a kind of a co-created, co-produced event. And I think the thing about the conferences is that we do have really good conversations, but people do take this back and make it back into their organisation. So it's not just something that we sit in a room and have lots of conversations and that's it. There's evidence from the work that we've done over the last few years in the conference that people go back and take best practice and use some of that in their own organisations, which is really, really positive. And again, really keen that we continue these organisations. I think the plan is for Thames Valley, for EDI to be really embedded and mainstreamed into everything that we do, but really help organisations lift their awareness around the importance of EDI as well. So that's a little about going kind of backwards. I think going forwards, we've already agreed at the last joint committee some of these priorities, our 3 priorities for equality, diversity, inclusion around leadership, belonging and culture, and policies and practices. So what we're going to kind of focus on for the first year at Thames Valley, based on evidence and what the intelligence is telling us, we're going to really look at our pay gap reviews, so gender, ethnicity, disability, and looking how we can reduce some of them. Also looking at intersectionality piece, so looking at our RES data, we know there's inequalities for Black and minority ethnic colleagues, but also we know that we've got a gender pay gap. So how does that look like then from that intersectionality lens? The RES, like I've mentioned, looking at recruitment, inclusive recruitment and career progression, and making sure that people have equal opportunities for career progression, but also our indicator around from shortlisting to appointment is equal as well. I mentioned around reasonable adjustments. There's lots of still feedback around these not being in a timely manner, people not understanding, gate managers not understanding. So how do we make sure that we've got our support of flexible working for our disabled colleagues? I mentioned the Anti-Racism Alliance, doing that in a Thames Valley concept. The Mirror Board programme, we're already working around delivering that for the new organisation and engaging with our partners. Had lots of interest from our partner organisations in getting involved in that. And then ensuring that we have inclusion, equality, diversity, inclusion as part of our board development, executive team development, and it's embedded into that. And then the bit around inclusive recruitment I've already mentioned, and the community engagement. How do we ensure, when we're looking at our new operating model, health inequality prevention, that we have an inclusive community engagement approach, and we've got the right communities around the table. think that might be it all. Thank you for that.
Thank you very much. Sandra, did you want to come in?
Yeah, thank you. I guess it's just a point of reflection because some board members will remember the conversation we had around our disappointment of some of the staff survey results with regard to, people feeling discriminated against. And I guess what Safina gave a great picture there of the best of both, of bringing Frimley and Bob together. And I think sometimes we've taken different approaches to things, but we'll get that real richness of putting those things together. I think the point around how we focus on making sure people going through the process of change now feel as supported as they can be. So lots of work with our networks in that space and making sure we are inclusively recruiting. But I do think there is a point at which we need to stop. And I know this is part of our plans, isn't it, Safina, about saying, what do we directly think is working best and what not? My fear sometimes is we put on an awful lot of events for people to learn and benefit from, and we get the same people going to those. So how do we target more for line managers? So they are confident in this space about managing any area of diversity. So it was just about that kind of, how do we now really mirror this and target this into what do we think is going to have the greatest impact, where we need to make sure staff are feeling well supported and able to progress within our organisation. Thank you.
Thank you very much, Sandra. And thank you. I now have Sajad, Ilona, Saqib, Sim and Tim. Thank you. Over to you, Sajad.
Yeah, so Safina, thank you for your presentation. Really, really comprehensive, really detailed, a lot of hard work. Thank you for you and the rest of the team. So just had a two-part question. First of all, in terms of the gender pay gap, I note from your presentation, it's not all explained by representation. Notwithstanding, there are legal implications about not paying people at the same level. What do you think that gap is then beyond the representation? What is driving that if it's not just about kind of representation? So that was kind of the first part. And the second part, obviously, NHS is not unique in tackling a whole series of things around this. But I see a lot in the corporate sector, what I call DEI theatre versus actually addressing it in terms of reality. So what can we as a board help you with in terms of that action plan, visibly and tangibly, in terms of making that actually happen and tangible improvements occurring?
Do you want me to take that now, Priya? Or yeah.
Yes, and then I'll gather a few together and then we'll move from there.
Thanks, Sajad. Really, really good question. And I think representation is one thing, like you said. We've got different pay scales for different roles as well at a senior level. That's an NHS England thing, so it's not something that we set. I think there's something around women tend to want to work flexibly in terms of caring role, maternity leave. So I think all these institutionally, these inequalities, systemic inequalities that exist, mean that that's happening in most organisations. So what I'm really keen to do is to do some engagement around this and really get into some of the detail around why we're not seeing this shift in gender pay gap for both organisations as much as we want to. Once we know that, I think what would be helpful for the board is to help make sure that we're asking the right questions and getting the right assurance around, are things moving? It's been a priority for us for the last couple of years, but it doesn't feel like we've shifted it as much as we wanted to. But I think it's a combination of, pay, flexible working, caring, responsibilities, maternity leave, penalties because women are going to have children. I think it's a combination of everything. But if Sandra or Caroline want to come in, no.
Thank you. Caroline?
It was just a quick one. I recall a really good report recently titled "It's going to take 30 years to sort out the gender pay gap in the UK." It's a good read. It's a bit depressing, of course, as well. But driven by care responsibilities, it is systemic. It exists across all industries. Really big disparities in finance and insurance industry, and then add age into it, and you've got a rather depressing mix. So I always think that the danger with gender pay gap is set against that context and that evidence base. What difference can we make within our system, given a depressing systemic picture? So how do you focus in on the right things? And I think Safina's spot on around, we're not going to solve all of this, but if you accept the evidence tells us that care responsibilities are a big driver of it, then what would we do together within our system to focus on that, whilst influencing and, as much as possible, advocating for change at significantly other levels across?
Thank you, Caroline. Nick, did you want to come in now?
I was going to sum up, Priya, but I suppose for me, I'm very conscious we're about to launch a new organisation, create a new organisation, building on the strengths of two legacy organisations, and clearly, organisational culture is all important in terms of the success of the Thames Valley ICB and indeed the success of the Thames Valley system. So, firstly, I think there's a really important job of work in terms of the board, how we behave. What happens around the board table, the decisions made by the board will have a profound impact on the wider culture. So everything we do has impact, has a ripple effect. And I think we know that, but we shouldn't forget that. And then secondly, the equality, diversity, inclusion agenda, which has been so well articulated by Safina, and Safina, very grateful to you for the presentation, indeed the work of the wider team, has to underpin our approach to developing the new organisation's culture and our organisational development programme. And I know already we're starting to do that, and we're supported by strong staff networks, etc. And we've got great leadership across both organisations, and we'll have in the new organisation. And I suppose we just need to keep coming back to this. It can't be something that is a once a year sort of set piece thing, picking up Sajid's theatre comment, which I would agree with. This has to be something that we review regularly as a board, something that we review regularly as an executive team, and it requires laser-like focus. But I'm confident we have the leadership in place to provide that focus. And I'd also say that there's been some great examples of good practice in both systems on which we can build. The Mirror Board being a case in point. And the fact that we have Safina here today as our EDI advisor stands us in good stead, not least because I'm not aware of such a role being incorporated in any other ICB board at the present time.
Thank you, Nick. Ilona?
Thank you, and thanks, Safina, for the papers and also your leadership in this space. The thing that struck me, and it partly feeds into Caroline's remarks, there's a slide in one of the gender pay gap decks that gives benchmarking data for the Southeast, and there are some quite stark differences there. And I was thinking, if there are ICBs out there who have done a better job here in terms of gender pay gaps, closing the gaps than we have, do we understand why? And is it something to do with the a different makeup of staff there or whatever, or not? And that it's back to your point, Caroline. What can we influence and control versus what within the remit of this board and this organisation? Should we just face facts and think, well, maybe we can't do so much there? And I wondered, do we understand? So where we've got ICBs that have potentially 10 percentage points better gaps than us, that's interesting to me, and I just wanted to check that part of our thinking is trying to understand that better and learn from it. Thank you.
Thank you. Let me bring in Saqib and then we'll come back.
Yeah, thank you. Thanks, Safina, for the presentation. And I think a couple of points that I've made in the past, but I will reiterate. As we move into the Thames Valley ICB, I think it's really critical that this has laser focus and the momentum is kept up. As Caroline's mentioned, that it's going to take 30 years to potentially deal with the gender. I think on the basis it's already probably been worked on for over 20 years. I think that's even more worrying. But a couple of points are, one, for example, on the on the gender pay gap, obviously it measures it across the pay grades. So I think it's also that at each pay grade that you have equality, which isn't necessarily always there. And then secondly, in terms of the ethnic diversity, sometimes you don't have the pipeline, you don't have the mentorship, you don't have the feedback, you don't have the pool of candidates, and you don't have presentation on interview panels on both sides of the table. So I think that has to also be worked on, so that you actually have people. I don't know what the percentage is now, but I think at the population level, I think 18% are ethnic minorities. But if you looked at the under 30s, it's possibly, I don't know, 30%. And, you know, are we getting 30% of our applicants from graduates and under 25s applying for our roles from ethnic diversities, ethnic minority backgrounds? I suspect not. And so that's kind of an area that I know the role of the ICB will be changing across system. It will be focusing more on the ICB rather than system wide. But I think we should still show leadership in that, as we have done over the past. Thank you.
Thank you, Scabe. Safina, would you and Sandra like to, Caroline, like to speak about the learning from other systems? Where are people managing to make inroads?
You want me to start, and then you can. So a southeast region equality, diversity, inclusion network is something that we've already discussed around how we share that best practice. So looking at the other ICBs, we're going to have a specific roundtable around sharing that best practice. So that's already happening, Ilona, just to reassure you that you know, we're looking at, but also nationally as well, which ICBs and organisations have done it well. So that's already starting. In terms of SACIBs, I'll just respond to that, and if Sandra and Caroline want to come. I think the inclusive recruitment work that we're doing is going to be looking at that talent pipeline. It's going to be looking at diverse panels, although diverse panels doesn't always mean that there's going to be diverse recruitment, which is, you know, a bit of a caveat. That's one way of doing it, but not the only way. So we've kind of really wrapped around the whole inclusive recruitment process, shortlisting, slotting it. We've got a real good lens on there to make sure that the points that you raised, exactly that we address them throughout the process, but also going forward, a commitment to continue the workforce race equality standard, this disability equality standard as well, and delivering that. But we'll make sure that we're still having a focus on them areas.
Thank you.
If I come in on this point as well, because I think, Saqib, you've raised almost a double risk for us there, because taking a look now at the new proposed workforce models for region and for ICBs, they're all seeing a shift up to senior roles. So the casualty of that is often the initial entry roles for people of a younger age group, not always, and I'm obviously generalising, but and therefore there's a double risk there, isn't it? If that's where the largest ethnicity difference is, and then we're also restricting that from an age perspective, we've got a kind of double risk there in that perspective. So that's something for us to really think about.
Thank you. Sim and Tim, please.
Thank you. And Sandra, triple risk, gender, age, as well. So it is tricky to look forward to. And I suppose I speak to you as kind of an advisor on EDI and chair of the CEQUAL group, which is the NHS non-execs from ethnic minorities. And that is really picking up on what Sajid and Nick have said and welcoming their comments very much, because equity inclusion is part of culture, and culture is everybody's business, and it starts with the board. And it's exactly what Nick says. It's about actually doing something. So that means the things you say, the language you use, and the effort you make as an active bystander or calling out poor behaviours or whatever they may be. It actually entails doing something rather than just reporting. So I think as you go forward in the new Thames Valley board, it's that movement of the dial that you will be accountable for, actually. And if the dial doesn't move, it's not about outsourcing the actions and the activities to another party or Safina. On her own, she will not be able to move the dial. This is a joint systemic effort. And I think what's really important is something that Sandra picked up on, and that's the impact, because there's a lot of exciting and good actions here, but there's a lot. And in my experience, actually concentrating on one or two, three things and being consistent with pushing those through so that you can recognize, identify the impact, and then focus is actually a better way of moving the dial. It's a bit like the scattergun approach. It feels good, it gives everybody a sense of comfort, but actually it's not doing the systemic work, which is deep, heavy, and painful. So my sort of advice to you is really to keep that focus going. And I just think it's important that it's not a talking shop, that you end up actually doing something, and that means on an individual basis. That could be meaning, that could be training, that could be reading, that could be spending time with colleagues that perhaps you don't usually spend time with. And I think Hannah said something really interesting to us today, is it's very easy to fall into echo chambers. So what's going to be very important is sort of stepping outside of that and really engaging meaningfully with our communities, our people, our population, and our staff. It's the only way to understand what's truly going on, rather than thinking that we know what's going on. Thank you.
Thank you, Sim. And Tim.
Thanks, Priya, and thanks, Safina, for a huge amount of work that you've done here. It's really informative and it helps shine a light on a lot of important points. I just want to slightly move the focus a bit onto the section in the report about safer workplaces and violence prevention and reduction, because obviously we've got a huge workforce, massive interaction with the public, and I know a lot of people sadly suffer pretty terrible incidents in the front line, which is clearly terrible for everyone involved. On that point, is there and it maybe this isn't the right forum for it, and if so we can have a chat offline, but there's a broader point around violence in society and how we as a massive employer and an employer with a heavy female skew about violence against women and girls, and how we can thread some more specific thought on that area into what the work we do as we move forward into the new organisation, because obviously it's a societal challenge, not just an NHS challenge or a Thames Valley challenge. We've got some great work I know you've done with Oxford OUH in terms of I think you had a get together back in October, which was great, but how we can try and sort of broaden the debate into just violence in society is clearly not a good thing. It's particularly perpetrated against women and girls, which clearly we've got to try and eradicate. And there's a lot of organisations, obviously a big government focus, how we can thread a bit more of that into our thinking and our culture. I'm not suggesting we've got a violent workforce, but how we can do our bit as a big employer and a big employer of females to try and there's a lot of allies at work. So that the male workforce can absorb a lot of lessons and learnings, which I think they need to do in society in general. So perhaps it's more for offline, but I thought it's important to pick up. It's a small part of a very big report in here about the violence and prevention and reduction, and just to make sure we don't miss that in the other important conversation we've already had. So maybe it's a chat we should have offline at some point. Thanks.
Yeah, just quickly, Tim, yeah, absolutely. And I think the work that we're doing around sexual safety in organisations through what the work all organisations have to do, we're going to definitely pick up that violence against women and girls wider. So yeah, absolutely. And I'm happy to have a separate conversations and thing that you want to raise. But yeah, rest assured that it's been picked up through the sexual safety work.
Thank you. Thank you very much, everybody. That's been a very helpful and rich conversation. And there's coherence, isn't there, in our approach to equity of outcomes for our populations and equitable progress in people's lives and careers as they are working with us. And many of the people that are our residents and patients are also our colleagues. And so that it's a helpful continuum for us always to have in mind. And that takes us then to our Work Well report, Caroline. So over to you. Thank you.
Many thanks, Priya. I've just got a couple of slides to bring this item to life. It's a rather large document that colleagues will have received, but I just wanted to bring it to life, particularly as we close down the two organisations and take forward into Thames Valley ICB. I know this has been a point of discussion informally with board colleagues about our strategic context, and particularly the publication of the Keep Britain Working piece from government. That in context shows that 1 in 5 working age adults are out of the workforce, and in particular ill health being the biggest driver of that inactivity. You may recall when this was published, the sorts of costs estimated to working age adults being not in work, and that Keep Britain Working document for me was one of the key things that pulled through in terms of our work in our systems currently and going forward in the Thames Valley ICB. Was focused on, one of the areas was the reform of the FitNote system and the amount of time that takes up, particularly in primary care, and the idea that freeing up GP capacity in particular would be one of the central tenets of that approach. I guess the other key area was workplace health, particularly into neighbourhood health strategy. So I think of our work as an organisation, as an employer. I think of our work as a strategic commissioner, and I think of our work as a partner, particularly with primary care now and into the future. The other area I wanted just to highlight in our sort of context was both the Frimley and Bob ICBs, our core partners in the Get Berkshire working plan. Again, national context about an 80% employment rate. Well, the Berkshire Get a Berkshire working plan, which we are a key signatory of and active partner in, also brings to life the local response to that Keep Britain Working report. If I move on then, so if that's the strategic context in terms of employment, how it links with health, the Workwell programme story is centred particularly on Frimley as was selected as one of 15 national pilot sites. So through to 24-25, the Frimley system was working as one of these vanguard pilot sites with a focus on with partners in DWP, DHSC in particular, being part of the ambition to support people into work. And as reported, if mental health is one of the main barriers to getting into work, then what was our pilot sites in the Frimley area, working with primary care in particular to address that. Fast forward to January 26, and DWP confirmed a national expansion of this pilot programme such that all ICBs are now being challenged to roll out their Workwell response. And in particular, the South East region looks like we're going to the South East alone be supported with about £30 million to roll out the learning from the current Workwell pilots into a new delivery programme. It's interesting that when you look back in terms of the work to date, and you put yourself in the shoes of DWP, DHSC in particular, the approach has been to trial something out, vanguard pilot models, create a change model, and then look to spread and scale it. Just have that in mind. So as we become the Thames Valley ICB, this is a summary of what the vision is for our new ICB in terms of how we will continue to support this work and the sorts of key benefits. So residents staying or returning into work, that we will enable the collaboration with employers across the Thames Valley, and that specifically a change to that FitNote process, particularly in primary care, what that might look like. So that's our learning. How do we take it forward? A set of the sort of benefits going forward for the Thames Valley. If I move on then, please, if that's the vision for Workwell going forward, well, why will it matter to the Thames Valley ICB? There are significant alignments with our role as a strategic commissioner, let alone our priorities. So in its broadest sense, as a strategic commissioner, then the integration of health, employment and well-being, as we know, is a key determinant of population health management. And how we work as a partner with local authorities now and into the future continues to be a priority. How we take this work and enable that as a determinant of our strategic objectives as well. You can start to see the direct links with that, and how we work, I suppose, particularly in the area of health inequalities and what work we're going to target. If I move on then, just a couple more slides. As a result of the change to and the dissolving of the Frimley ICB, colleagues in the team, there's a very small work but very capable Workwell team, and the Frimley ICB that have been in effect guiding DWP through actually the ICBs are changing. So there's a transition, sound familiar, into North East the Hampshire Isle of Wight ICB. There's a transition into the new Surrey Sussex ICB, and then we're classed as a new ICB, as a new Workwell site. So the job of the team has been to assure DWP that whilst the boundaries split, there's a consistency to what we've learnt in the Frimley pilot into Thames Valley ICB, and a partnership approach with Hampshire Isle of Wight and Surrey Sussex on, as money comes into the southeast, how do we support our fellow ICBs in the translation of this work. What that means for the next slide is that we're being approached as what will be the Thames Valley ICB Workwell programme to say, do you think you can come and support us in Surrey Sussex? What that might look like, and potentially an at-scale model in the southeast. If there's £30 million in the southeast for Workwell, well, what would you scale out of the Frimley Vanguard? What would we support partner ICBs with? Or what do we continue to do just for Thames Valley ICB? So a set of choices coming up for Thames Valley ICB in, you might call it a hub and spoke. You might say we'll simply ensure the safe handover into Hampshire Isle of Wight and into Surrey Sussex. We might manage part of the work programme for those ICBs. We might actually set up something that is a hub and spoke model across the southeast, something done once rather than done 4 times across the southeast. So there are some transition options, but there are some must-dos for the Thames Valley ICB. And as I say, there's a sense of how do you spread and scale what works best? How do you continue to deliver as part of our strategic objectives this focus, with a small and a very capable team that will sit with Sandra as Chief People Officer, and from a governance perspective, be managed through the Living Well board, given our relationship with public health and that governance infrastructure around the Living Well portfolio board. So last slide. Is just to say, in the context of those transition options, our commitment is to continue the stability of the team, the work that's been going on, land that safely in the Thames Valley ICB, continue the strong working, particularly across Berkshire, and the work that Slough Borough Council we're actively involved with there, and step through the options to do it once across the southeast, while supporting partners, Hampshire Isle of Wight and Surrey Sussex in particular. So hopefully that brought it to life. As I say, that was quite a weighty document that from a governance perspective has been through the executive. We've signed off the plan, but this is just an indication of, yes, we'll do the plan, but there's more work ahead for Thames Valley ICB. If we can take the slides down now, please, Kelly, thanks ever so much. And happy to take any conversation, any questions.
Thank you very much, Caroline. That's been a really helpful and comprehensive note there. Such an important part, or an often forgotten part, of reducing health inequalities and increasing healthy life expectancy. So an important aspect for us. Sajad, Paul, and then Ilona, please.
Yeah, Caroline, this is such a fantastic initiative because it goes to the heart of what we should be doing going forward, and it starts to address upstream many of the things that we've talked about at this board, but never get to. And the fact that it's funded by a central government program, I think kind of almost augments, you know, kind of our innovation fund, you know, type thing. So it's bringing extra money outside the system to kind of address some of our objectives. I suppose my only question to you is, one, were there any things in the Frimley pilot? I remember reading in some of the past papers that we were struggling to get referrals and that kind of thing. And my second part, how does this intersect with other early intervention things we're doing? So for instance, we've heard at the board previously, we're doing diabetes focus in Slough, for instance. And that's going to be obviously, you know, one part of why maybe people are ill. So how does this intersect with some of the stuff maybe that Hannah will be doing going forward in terms of some of those initiatives? You know, just making sure it's all joined up. I assume it is at the exec level, but just kind of give the board a sense of how you're going to manage that.
Great. Shall I pick up that one, Priya? Great question, Sajid. The first one in terms of the Frimley learning and targets. So alongside the other 14 initial pilot sites, one of the areas of measurement of the pilot was referrals into the scheme. And I think it's fair to say all of the pilot sites were set very, very stretching goals. The idea that you could day one build the program and secure all of the referrals, you know, there weren't many, if any, pilot sites that achieved the targets for referrals that were initially set. We are now agreeing new targets with DWP in particular about, based on the learning, what are good measurements? What do we actually need to measure? Is referral the best proxy for what we're trying to achieve? So there's quite a challenge going on about, are we actually measuring the right things? Getting a referral in the first place is a measure, but is it the measure that this is the right measure of outcome? I can go on in detail, well, the team can go on in detail about that. So yes, from a first look, we didn't achieve the referral rates, but we're, as you can imagine, working with Hannah's team, Mark Selman in particular, also challenging the DWP about what are the right things to measure in this context. Your point about and how do we work, one example would be the Health and Work Steering Group that Slough Borough Council set up across the whole of Berkshire to say the interplay between health and work, what are we focused on? That's one place where the diabetes conversation comes to life. The other place is the Living Well Board, and how do you bring these things together, again, to deliver more effective impact. Again, happy to pick up offline with you, but the architecture of which groups are looking at this and how do they maximise impact. The main one at the moment across Berkshire is that Health and Work group that also feeds into what's called the Prosperity Board that brings health and work together.
Thank you. Paul and Ilona, please.
Caroline, this is kind of joyous, actually. It's, as Sajid rightly said, it's exactly what we should be doing, and the opportunity for leadership here is very significant. You know, if we're really going to address the needs of our population, we need to think about how we support people to both stay in work when they face health pressures, but also how those people who are out of work to find work. So 3 quick questions really. First of all, do we now know in our new footprint what proportion of the workforce is employed by the NHS? And if I'm sure we don't yet, but if we do, once we do, it would be really interesting to think about what the role is as an employer. Our role is as an employer in supporting this programme. That's my first question. Second question, thinking about the broader conversation we've just had with Hannah, to what extent can we use this as a way of creating powerful and effective conversations with other employers in the area, the large employers, whether it's the universities or the private sector, or indeed the voluntary sector, to be a part of this. So this is a kind of vehicle for creating really strong partnerships and of course with other parts of the public sector, particularly local government. And then my third point is really just to take us back to the point I was making earlier. And I suppose I just want to identify 2 groups here that the Keep Britain Working review highlighted. So the group I mentioned earlier, young people with mental health issues, where the return, I'm not going to use the word return on investment because it's not about that. It's about the return for those young people who have probably experienced the worst of COVID, followed by the worst of an economic challenging period. And there are lots of young people who are not working because of their poor mental health. So getting that joined up connection between access to care and support and then access to support for work is such a big opportunity for us. And then secondly, just thinking about those older workers in their 50s often, who not that old obviously, but by definition those older workers who may be needing to stop the work they're currently doing because of musculoskeletal issues and others, big group highlighted by the review.
Yeah.
I think just really thinking about how we particularly pay attention to those 2 groups, both from a health point of view and from a work point of view. So this is absolutely the sweet spot for what an ICB should be able to do to bring together the collective interests of a community from both a health and a work point of view. So I know I won't be around for much longer, but if there's anything I can do to help on this, please do shout.
I'm almost tripping over my word. Don't worry, we will keep in touch. The network of networks is really important to us as we go forward. But Paul, you've raised 3 or 4 really important things. And I just want to pick up Prash's point as well in the chat. Yes, local employers, Thames Valley, no, don't have the number to hand unless Sandra's worked it out already in terms of the proportion in the Thames Valley that would be employed by the NHS. But that whole Anchor Institute concept, wherever you draw the boundary, the NHS is one of the biggest employers in any geography. So that relationship with other large employers, I know the team that are working on this, what will be the Thames Valley team, are already in live conversation with Waitrose headquarters, because wherever the headquarters is on our patch. If you think about the uniqueness of the academic institutions on our patch, let alone the NHS as major employers, there are some incredible employers on the Thames Valley patch that you kind of step back and think, my God, we have a huge opportunity here. So yes, the team are already in touch with some of the headquarters, large employers, to say, how do we do it better? What have you got in place for attracting local people to those jobs and in support of their health? That's a key plank of the work. Prash's point I just wanted to pick up was about and how do you balance what could potentially look like more burden into primary care. The area of work I'm particularly curious about is this footnote process. The assumption that could be, we could apparently relieve the burden for GPs in terms of the footnote process, redirect that into a different OC health approach, and make that work better at the level of practice. I'm going to pick it up with Prash, George and Hugh at a different moment to say, yeah, that sounds good. In practice, how is it actually working? Is it still really confused? Is that the answer? And what are we learning in this past year about the assumption that the fit note process unlocks a huge amount of that? Young people, obviously, absolutely critical. Do you know, one of the feedback I'm hearing from the team is when they're out and about, as imagine that Get Berkshire working piece, they're out and about and encouraging individuals to come in with their parents, with their carers, and say, how can we help you? Top message that comes out of any of those types of environments is too confusing. I've got a DWP initiative doing that. I've got a health initiative doing that. That one-on-one conversation about how do we support you and how do we wrap around support given your unique needs is the biggest blocker to some of the return, in effect, that could be enabled faster. It's just too confusing. And what we think as individual public sector bodies is stripping away some of that confusion is often layering on more confusion. So that one-on-one support, signposting, directing with loved ones, the best support for young people by miles is showing the benefit. And then the 50 plus, some of the impact that's being had through the what's called Joy app and Get You Back to Work app, that MSK app and how we support people through that is one of the unlockers of the 50 plus work. Again, there's loads of detail that the team have got around not just being part of that initial 15 Vanguard sites, but also the what's our unique focus in for Thames Valley. We can share offline, and it gives me a good excuse to keep in touch with you, Paul, in terms of joined upness, the network of networks.
Thank you. I'm going to bring in Ilona and Prash and then give Nick the final word.
Thank you. Really interesting conversation and great to get your update on this, Caroline. And the kind of expansion to the Thames Valley geography feels like an exciting moment. And quite a lot of what I was going to flag has already been picked up. So I was keen to understand how this feels from a primary care perspective. So thank you, Prash, for chipping in. And that also linked into my other point that while this feels logical and exciting, I think the evaluation is key, and in particular working out where we as the kind of system convener for the NHS in a patch can add the most value versus where are others better placed to step in and lead, etc. So I just wanted to re-emphasize, I know this is part of the programme, that the evaluation feels important and that there's, are we having the impact ultimately that we want to here? So hearing what you were saying, Caroline, about debating what are the right measures, etc., feels important. And then just I wanted to understand that the funding, given the expansion, is the funding kind of broadly equivalent per capita going forward? Are we having to change what we're going to do to fit a new style funding envelope, given the broader geography, or is it kind of rolling out in the same way it was operating before because the funding is equivalent per capita? That was just a quick query, if I may. Thank you.
Quick answer on that. The funding is linked, yes, to the size of the geography. It's outside of the £19 target, thank goodness. One of the few things that DHSC and DWP quickly got to grips with and said, no, build the teams, they have to be located in ICBs, and don't worry, they don't count as part of the £19. So there is a small expansion of the team just about to happen, jobs available for ICB and system partners to expand that team to then focus on. Quick answer to that one.
Thank you. Prash?
Yeah, no, thanks for the presentation. I mean, it's such a complex area. No one needs to be told this. And as a GP for the last sort of 20 plus years, it's such a great way of supporting a patient as they recover through either mental or physical illness, and they go on to work to be incredibly productive. But obviously we know that society is changing. And when you look at the reasons for people's absences, which often have to then be confirmed or rubber stamped by their GP, I mean, it can be so complex because where I've had every type. I've had patients who are so thankful for the support that I've been able to give them, because what you've often got is occupational health advocating for the workplace. So you've got to take that tension on. And then I've had those areas where I'm genuinely trying to help a patient say, you really ought to go back to work. And I've had reams of complaint letters. And the GP is very much in the middle of this because they are, genuinely caught between a rock and a hard place. And for me, it's great that we're discussing this on the public board, because it really has to be a public decision about thresholds for what triggers people, thresholds for what worries people, and it's all about thresholds. My biggest fear is this will be an underfunded piece of work, and it will be run with if it's a central thing. I hear people saying that's to be congratulated, but it's important to understand what that central agenda is. And I reckon we as primary care will probably be slam dunk straight into the middle of it if it's not built correctly, because every single GP wants to support their community, their patient, either through a period of illness, but also to gently encourage them and to say that actually your career, your work, it's one of the most important things with regards to you, your recovery, etc. And absolutely, on Paul's point, this is the cornerstone of our older workforce. We need to keep our older workforce healthy. We need to support our older workforce, because I don't believe that we have the number of youngsters, etc. But I am concerned I'm glad that you're going to get primary care in to really talk about it, but I'm worried, I'm genuinely worried that we, it won't be taken in the levels of nuance and detail, because we're probably going to be under-resourced by way of people and finances. But I'm glad it's happening, and I'm more than happy to help in any way, shape or form, because myself and every other GP, we've got 20-25 years of all that nuance. Thanks.
Thank you very much, Prash. I'm going to hold our conversation on this topic just for a moment. I'll bring you in a second, Nick. Thank you. We have Sam Burrows, our Chief System Development and Engagement Officer, will need to drop off this call at 5:30, and he's going to answer our question from the public. So may I bring you in, Sam, at this point?
Yeah, thanks ever so much, Priya, and sorry to change the flow of the meeting. It's such a good and important discussion that we're having. But I did want to make sure that before the meeting came to a close, we were able to answer the question that we've received from a member of the public around patient and public involvement, particularly following review of the commissioning intentions document, which we published before Christmas. So just on behalf of the board, I wanted to thank the member of the public for the question. It's a really important point. We've noted the remarks as the board. I just wanted to underline how committed we are to patient and public involvement as a core part of our approach, whether it's around our commissioning intentions or service redesign, or the other breadth of the work which we undertake as an organisation. And we will put more information around our approach to this out in the year ahead as we establish the new organisation. So just thank you from us, and there'll be more to follow on this.
Thank you very much, Sam. I didn't want us to miss that point. So thank you. And back to you, Nick.
Brilliant, thanks. And Caroline, firstly, thank you for the presentation and your leadership in relation to this, and your enthusiasm and energy are palpable, which is fantastic. And I think that reflects the importance of this agenda and the potential we have as a system. Just building on Paul's point, obviously the interface with mental health services is of fundamental importance, particularly talking therapies. And there is a lot of concern, understandably, regarding the number of people out of work who have mental health conditions of one kind or another and may benefit from talking therapies to address those conditions. So I know that's already part of our thinking, but just to flag that it's of fundamental importance to progressing this.
Thank you very much. I would like to bring that section to a close and to note our formal approval of the public sector equality duty reports and gender pay gap reports for both systems. So thank you for that. Let's move now then to the board assurance frameworks review, and you will note there also the AAA upward reporting from audit and risk committees and the joint finance and performance committee. Thank you, Caroline.
Yes, on the board assurance framework, I suppose in the context of no longer existing in 15 days' time, this is just a standard update for both boards about the closing down, in effect, of the two board assurance frameworks. I just wanted to assure colleagues that as we go live as Thames Valley ICB, the importance of not just the mechanics that are around getting us set up. The board assurance framework for the Thames Valley ICB will be absolutely critical, and we'll want to set that up alongside our risk management framework very quickly, such that we're able to, as Thames Valley ICB, set out our board assurance framework within Q1 and get that through to our first public and private meeting later on in Q1. So nothing to highlight at this stage in terms of the Bob and Frimley board assurance framework in the context of closing down the two organisations.
Thank you very much. Ilona.
Thank you, and thanks, Caroline. I was going to say two things. One, I really welcome the commitment to getting on top of the new board assurance framework for Thames Valley early on in the new reporting year, and second, and to accept that it will evolve. So, you know, getting an early version that we can begin to frame our thinking around and then develop it feels more important than spending longer perfecting something that will probably change anyway. So that was point one. So thank you very much for that commitment. And point two is just to flag the work that's been done across the board, kind of from the bottom up perspective, if you like, looking at the more operational risks and ensuring that as we transition into Thames Valley, we're not losing sight of any of those issues. So I thought that was worth flagging, because I've taken assurance from that work that's been reported up through certainly the Frimley Audit Committee, that we won't lose sight of any key areas of concern at the moment, and they will get picked up under the new arrangement. So I just thought that was worth flagging. Thank you.
Thanks, Ilona. Yes, signed off the for the Thames Valley ICB, the risk management framework, also the that approach to transitioning the two risk reports into one. So yeah, absolutely. Thanks for flagging. Well underway.
Thank you very much. Any other comments or questions? And I can't see that. Good. Okay. I know that we are saying as the two boards come to the end of their own individual journeys, we are all stepping off these boards, and there was a new board appointed for the Thames Valley. So in very many ways, we're all saying goodbye in this moment as this last joint committee, though some will be on the new Thames Valley board. And there are very many thank yous to say to everybody that has been part of the two boards and the joint committee as we've come together, and to look together at what the evidence shows us about what our population across the Thames Valley needs, and how we turn that actionable insight into real concerted and coherent action. So I'm very, very pleased that we're moving forward together in this new way. Number of people I know would want to say a few words, and I'm going to hand over first to Sim, please.
Thank you, Priya. Yes, this is my last board meeting, and it feels really sad. No, I've got a transition board meeting tomorrow, thank goodness. But I just wanted to say thank you to colleagues, and I wanted to say thank you to Bob colleagues especially. We've heard a lot about Frimley. There are a lot of Frimley executives that sort of sit on our board there, but I just want to reflect and say, I know Nick described it as Bob's choppy waters, but sometimes it felt like a tsunami to some of us. So I think I'd like to take on Paul's wise words about the learning. When you've been through some very tricky times, there is great learning to be had. And I would really encourage Nick not to lose that, because just as a reminder, Nick started as an original colleague on the board as a Ned in Bob, then became interim CEO, then became substantive CEO for Bob, then became Thames Valley CEO, and is now a director nationally. So his transition through that time, despite the choppy waters, has been really spectacular and important. And I just think we should acknowledge that trajectory. I'd also like to thank the fellow Neds who started on our journey. It's been really difficult, but we stuck with it. And I'd like to thank Priya for taking on the board chairman role, as well as her Frimley role. This could have been very difficult. It could have been more complicated than actually she allowed it to be. So I think there needs to be recognition in that transition. Without that leadership from both, I think, Nick and Priya, it would be a difficult position we would find ourselves in today. And I think the real test is the comparison with some of the other systems in the Southeast. And you've heard colleagues tell you how we're faring. So just a great thanks to you all, a great thanks to my Frimley colleagues. I've learned so much in such a short time. So it's quite emotional, actually. The wonderful thing is I remain because I'm a resident. You will be treating me and my family, and I have an absolute commitment to this system because of the history, because of the difficulty we've all been through, because of the resilience it's allowed us to gain, and because I have shares, if you like, in this system. And I am here, and I can't wait to have a look at Thames Valley and what you do for us as residents. So thank you all. Thank you, colleagues. It's been a real pleasure. Thank you.
Thank you very much, Sim. I think you bless us all with your kind and wise words as we step forward. You've been an amazing leader for our system and really set the tone for what we aspire to. And I know that we go well in our service of the Thames Valley population, knowing that trusted leadership is vital to make sure that things will work for us. Thank you so much, everybody. We are next coming together, not actually next coming together. The Thames Valley ICB board will meet in public on the 20th of May of this year. So thank you very much. Thank you. Today is just our last joint board. My goodness, the amount of work that is continuing outside these board meetings is enormous. Very many thanks to all our executive colleagues and colleagues across the system, and our leadership across the system has been hugely active in making sure that we make this transition well and also fulfill all our obligations as we do that to our population. So thank you, everybody. Have a good rest of the day.
Thanks, Priya. Thanks all.
Thanks, everyone.
Bye.
Thanks, Priya. Thanks, everyone. Bye-bye.